Okay, hello. This is part 2, urinalysis and body fluids for stone. This session we're going to review normal urine volume and terminology, define factors affecting urine volume, outline specimen collection and handling, discuss physical and the chemical exam of urine, such as specific gravity, color, clarity, and odor, chemical tests, and clinical significance of them. Okay, how much urine a person produces a day depends on the body's state of hydration. So the normal range of urine output is about 600 to 2,000 milliliters in 24-hour time period, with 1,200 to 1,500 milliliters per 24 hours being the normal adult output. There are many factors that affect urine volume, how much fluid you're taking in and how much fluid you're losing related to other functions, not just kidney functions, but non-renal functions. Also, factors that affect urine volume have to do with hormone levels, diuretic and antidiuretic hormone levels, and how much dissolved solids like glucose and salts are being excreted. Here are definitely some terms that you should know, and I can't imagine that you might not have board exam questions about these. And let me know if you have a really fun way to memorize these. Otherwise, unfortunately, I think the best way to know these is to memorize them. Oliguria is decrease in urine output due to dehydration. Anuria is no urine output, usually due to kidney failure or damage. Nocturia is increased urine output at night. And polyuria is increased daily output of urine, and this may even exceed greater than 2 liters per day. Usually polyuria is caused by diabetes mellitus or diabetes insipidus or ingestion of diuretics, lots of caffeine or alcohol. Collection and handling of urine samples. As much as you might not enjoy handling urine samples, it is part of the job. Urine should be treated as biohazardous material or substances. You just don't know how much blood could be in urine, and I just feel, some people may disagree with me, I feel that urine is definitely a biohazardous substance and should be treated as such. As far as being collected, you want to use clean, dry cups with lids. In some cases, you may need to use sterile cups, and I've worked in many labs where that's all we had was sterile cups. We didn't differentiate between the people who needed a urine collected for microbiology versus just a random urine sample. So there really wasn't much of a choice, but some laboratories do choose to differentiate and will have different cups for different reasons. Obviously, labeling, this is all pre-analytic. Labeling is, of course, important with your name, some kind of unique identifying number, maybe it's a hospital ID, whatever your facility chooses for that. And then date and time of collection. Now, a lot of times you're not the person actually collecting the urine, the patient is, but definitely if you are assisting or nursing staff definitely should perhaps put their initials on a urine label. Other things about urine labels, don't label the lid. The lid is going to be taken off for analysis. And if you're doing 10, 15 urine samples all at once, because that's how fast we go in the laboratory, you could get lids mixed up with cups and containers, and now you have a big mess. So the actual container it is held in needs to be labeled properly. As far as rejecting samples, I've worked for different laboratories. Some were much more stringent than others. Urine samples are pretty simple to collect. They're, generally speaking, don't produce pain while collecting them. Therefore, I've worked for labs where unlabeled urine samples were simply garbage, no questions asked, and recollection occurred. Other laboratories were a little bit more lenient, and nursing staff or other staff were allowed to label a cup or have a chance to identify the urine. That's up to the management staff at the facility you work for, and you need to follow the rules accordingly. I've worked for laboratories that had a pneumatic tube system, and we've at one time received 3 urine samples at the same time, literally. None of them had labels. Have no idea where they were supposed to come from. Well, sure enough, pretty soon we have ER calling. You have our results yet? We have urine over here. We don't know who it belongs to. They expressed that they will be right over to label that sample, and so we very nicely lined up all 3 of them and challenged them to identify which sample came from the ER. Of course, they couldn't do it, and all 3 of those samples obviously had to be recollected. But don't be so quick to throw them away. Sometimes, people make mistakes, people get and definitely follow your laboratory's protocol. Urine needs to be analyzed within 2 hours of collection, or it needs to be preserved. And there's many different ways to preserve urine. The most cost-effective and one that probably is the most effective is refrigeration. You just simply put it in the refrigerator. There are also chemical additives, and you would need to follow directions as far as how much chemical to put in and what type of chemical, depending on what testing is being ordered. I once worked for a laboratory where they had a separate OB clinic across the street, and we would get just volumes of urine from that OB clinic, obviously for screening OB patients. And it was kind of funny because we'd always get a deluge of urine samples at a certain time of the day, but it was interesting because for a while they were all room temperature, and we'd get them all at the same time. And we were noticing that the collection times were much, much earlier in the day than what we were receiving. And apparently they weren't following protocol and were not reading these samples and just kind of sending them over all at the same time. Well, we quickly caught on to that and had to correct them. If they wanted to save their samples and batch them, they definitely needed to be refrigerated. Otherwise, they needed to send them over within 2 hours. So pay attention to that, and remember, the results that you put out are only as good as the sample that you get. Okay, so preservation of urine is very important. Refrigeration will decrease bacterial growth, but it'll also precipitate out amorphous phosphates and urates. You need to bring urine to room temperature before testing. Chemical preservatives generally do not interfere with testing, but you need to look out for pH, which could be altered by chemical preservatives, especially, obviously, acids. Changes in unpreserved urine, if they are not in the refrigerator or chemically preserved, could have increased pH, increased nitrites, bacteria, turbidity, decreased urobilinogen, glucose, ketones, and bilirubin. Formed elements can be destroyed, and colors can change. So lots of things can happen if you don't preserve urine properly, and can lead to inaccurate results. Probably very familiar with the different types of urine specimens. Sometimes a first morning specimen is ordered. You're probably very familiar in practicum with the random urine, possibly a fasting urine specimen for those individuals who are doing glucose tolerance testing. 2-hour postprandial specimens as well. 24-hour collection. You should be able to know how to instruct a person to collect a 24-hour urine, or any of these types of specimens for that matter. Catheterized specimen, something that the nursing staff would be performing, but they need to indicate somewhere on the requisition or the label that that urine was from a catheterized sample. Midstream clean catch is probably pretty popular and familiar to you. Suprapubic aspiration is an invasive procedure performed by nursing or physician staff. And then there are different ways and tricks to obtain pediatric specimens. A lot of times there are little collection bags and whatnot that can be attached onto the children or in their diapers in order to collect that urine sample. I apologize, my phone is ringing at this time, and I'm going to ignore that. Okay, so be familiar with the types of urine specimens and what you would need for them to be properly collected, and be able to explain that to your patients. Well, once you get the urine into the laboratory and you're ready for testing, the first things we look at is color and clarity. Lots of different colors of urine, lots of different variations of yellow. Normal color is usually straw or a lighter yellow. Clarity is how clear is it? So if you can read newspaper article on the other side of the urine when you hold it up in your urine cup, that's pretty clear. Other descriptors for appearance or clarity would be turbid or cloudy or milky. And then colors, pink, yellow, red, orange, green, blue, purple, you name it. It just runs the gamut. Black, brown, port wine color. And we have a list later on in the presentation here that shows all the variations of color and their clinical significance. Odor can give you clues to things, but it's not necessarily something that we report out. The more experience you get in your analysis, the more things that you will correlate with odor, especially bacterial infections. Diabetes patients tend to have a very distinct odor to their urine, and certain substances that may be present in urine will lend itself to having very distinct odors. So as far as color is concerned, changes in color have to do with normal metabolism, disease states, diet, and physical activity. Once again, normal yellow or straw-colored. Abnormal colors are listed there. Colorless or pale yellow can also be normal, but that can also indicate some abnormalities. Remember, the color of urine is due to urochrome. You can have dark yellow urine. That, again, may be fairly normal and just due to some level of dehydration. An intense yellow, amber, or orange color could be due to bilirubin. Red or pink could be due to blood or hemoglobin in the urine. And again, there are lots of different variations to this. Greenish or bluish urine could be due to, maybe Pseudomonas infection, possibly things that were ingested. Brown, black urine would definitely not be normal. Can be due to melanin or different amino acidopathies present. So lots of different colors. It definitely is something to be noted on the report. I have worked for labs that did not bother reporting out color and clarity anymore. I think it just depends on the laboratory and physicians are wanting in their reports. Clarity, and then some descriptors there. Clear, hazy, slightly cloudy, turbid, milky, bloody. You want to use descriptors that are consistent with what others are using in the laboratory, so you don't want to just make up stuff. And I've worked for quite a few labs in my career. They stay pretty consistent. And you just have to kind of get a feel for what the others are reporting and ask for a list if you're not sure. Some odors that might be common that you might need to be familiar with. Once again, this is not truly part of a urinalysis report. However, it could be useful to the physician. Normal urine does have a distinct odor. You probably all know what that smells like. You can have an ammonia smell that's due to bacteria. Strong odor, very concentrated urine sometimes smells very strong. You have a sweet or fruity odor, and that's usually due to ketones present. Probably diabetes. However, individuals that have been really, really sick for a while and that have lost a lot of fluid and probably have vomited a lot, their bodies are converting fat to ketones as well. I have seen that in severely ill children before, where they've had days and days and days of vomiting, and ketones were definitely present. Maple syrup urine disease, definitely you could have a distinct sweet smell to the urine for that disorder. And then many, many, many others, and we're just not going to go into it in that much detail here. You'll have to review that on your own. But various foods, if you've ever eaten asparagus, the next day, your first morning urine smells kind of funky, and that's just due to the asparagus. Specific gravity, the definition is the density of a substance compared with the density of a similar volume of deionized water at a similar temperature. Specific gravity is influenced by the number and size of particles dissolved in that urine. Specific gravity, we talked about a little bit in the last session. It determines the renal ability to reabsorb. How well are those tubules reabsorbing things? It happens to be the first renal function to become impaired in the case of damage or disease. So this can be a very early indicator of something going wrong. Detects dehydration and abnormal hormones. We can measure this with a refractometer, a urinometer, or the dipstick. When a specific gravity is low, that can indicate the presence of disease like diabetes, insipidus, glomerulonephritis, pyelonephritis, indicating the loss of the kidney ability to concentrate urine. Could also have a low specific gravity with very, very large intake of fluid. I have seen this. I've seen very, very dilute urines that we weren't even sure were urine at all. Matter of fact, we needed to run creatinine and BUN testing on it to make sure that in fact it was urine and not water from the tap. You can have high specific gravities, obviously for dehydration, also adrenal insufficiency, diabetes mellitus, liver disease and disorders. X-ray contrast media can make a specific gravity be very high, and also congestive heart failure. Some terms you should know. Isothenuric, this is when you have a fixed specific gravity at 1.010, and this means that the glomerulus entering, or the filtrate entering the glomerulus has a specific gravity of 1.10. So what this means is that the tubule system is not concentrating and not diluting the urine the way it should, meaning if it comes into the glomerulus at 1.010 and it's leaving your body at 1.010, not a whole lot is happening in between. So hyposthenuric is less than 1.010, and obviously hypersthenuric is greater than 1.010. That rounds out the physical exam of urine. Now we're going to move on to the chemical exam, and I have the reagent strip pretty much listed here for us, and we're going to talk about each of these individually. I also have the most common control tests listed here, which we'll also talk about individually. So let's start with pH. The normal pH value is 4.5 to 8. On the strip itself, it utilizes the methyl red and bromothiamyl blue. Acidic urine, you can find acidic urine with high protein diets, respiratory metabolic acidosis, diabetes mellitus, and after normal sleep. Alkaline pH of urine occurs after meals, after vomiting, increased consumption of vegetables, renal tubular acidosis, respiratory metabolic alkalosis, urinary tract infections, and also delay in testing, so the urine wasn't tested in time within that 2-hour time limit. Protein. The reagent strip detects albumin. It uses tetrabromopheno blue. The principle of that procedure is a protein error of indicators. If the strip is in the urine too long, you find a pH greater than 9. False positive. False negatives are due to dilute urine and other proteins. Normal urine protein is less than 10 milligrams per deciliter, and protein is a really good indicator of renal disease. It's very diagnostic for renal disease. You really should not have a lot of protein in your urine. The different types of protein that can be present in urine are albumin, which would be detected by the reagent strip, microglobulins, Tam-Horsfall protein, and Bence-Jones proteins. Glucose. Conditions where we would see glucose in the urine: diabetes mellitus, impaired tubular reabsorption and disease, central nervous damage, thyroid disorders, and pregnancy. So all of these conditions would warrant a urinalysis. On the reagent strip, glucose oxidase and peroxidase is employed to come up with that reaction. False positives can be due to strong oxidizing agents like bleach, and false negatives can be due to increased ascorbic acid, also known as vitamin C. So this is one parameter where you do have a renal threshold for glucose. And so anytime the plasma glucose level is right around 160, 170, 180-ish, depends on what textbook you're looking at. But there is a threshold, so anything higher than that level, the glucose gets spilled into the urine, and then it would obviously be detected on the urinalysis dipstick. Ketones. The reagent strip employs sodium nitroprusside, and that is used to measure acetoacetic acid, which is one of the ketones. There are three products of fatty acid metabolism: acetone, acetoacetic acid, and beta-hydroxybutyric acid. It is assumed if the one that is detected by the dipstick is present, that the others may be present. Ketonuria is the term for ketones in the urine. This is normal. You should not normally have ketones in your urine. Times when a person might have ketones in their urine would be diabetes mellitus, insulin monitoring, electrolyte imbalance, dehydration due to carbohydrate loss, which can include starvation, exercise, rapid weight loss, vomiting, so on and so forth. The next pad on the dipstick is blood. There are different types of blood that can be detected. Hematuria is literally blood in the urine, and this means intact red blood cells. Hemoglobinuria is hemoglobin in the urine, meaning the red blood cells somewhere along the line burst and release the hemoglobin into the urine. Myoglobin is a protein that is found in muscle tissue. It's very similar to hemoglobin, but that also can be found in urine. So intact red blood cells possibly could be there. Usually that is displaying a speckled on the dipstick. Hemoglobin in the urine is generally displaying as a very smooth, uniform color change on the dipstick. And myoglobin also would more than likely look fairly smooth. There are additional tests just to detect myoglobin, and it just depends on the capabilities of your laboratory. Reasons you might see myoglobin in the urine would be crushing injuries to muscles. The reagent strip will detect pseudoperoxidase activity, and we've already discussed the speckled pattern and the uniform color for hemoglobin or myoglobin. Interferences. False positives can be due to vegetables and possibly E. coli peroxidases. False negatives can be due to vitamin C, nitrates, formalin, and captopril, which I believe is a blood pressure medication. But I'm going to look that up right now. Captopril, yes, is a hypertension medication. Okay. You want to think about, when we're talking about blood, what kind of color and clarity you're going to see with a bloody urine. So if you have a red urine and it is cloudy, you want to think about, well, what would be in there? If you have a red urine and it is clear, what would be in there? So think about that. Get that straight in your head. And we'll be quizzing you on the live Q&A about that. Okay, the next pad on the dipstick is bilirubin. Bilirubin in the urine can be due to hepatitis, cirrhosis, biliary obstruction, and liver diseases. We have conjugated and unconjugated bilirubin. Getting a little bit into clinical chemistry here. Conjugated is water soluble. It is excreted in the urine. Unconjugated is water soluble and cannot be excreted in the urine. So this can give us really nice clues, or give the physician really good clues as to what may be going on with the patient if they don't already have other clues. So conjugated bilirubin would be found in the urine because it can be excreted, and examples of this would be perhaps a bile obstruction, which would be positive for bilirubin but negative for urobilinogen. Unconjugated bilirubin would not be excreted in the urine, so you would have a negative urine bilirubin pad, but it would be positive for urine urobilinogen. You need to take a look at the pathway for hemoglobin metabolism to truly understand this, and also get that clear in your head. Why would you see bilirubin in the urine, and why wouldn't you? So I'll be quizzing you also on that in our live Q&A session. The reagent strip is utilizing diazonium salt. False positives are due to highly pigmented urines. False negatives could be due to old specimen, obviously exposure to light, increased vitamin C or ascorbic acid, and nitrites. Urobilinogen is due to conjugated bilirubin that gets reduced by urobilinogen by the intestinal bacteria. This can indicate if it's present in excess. There's always going to be small amounts of urobilinogen in urine, but can indicate early liver disease, hepatitis, and hemolytic disorders. The reagent strip uses the Ehrlich's reagent or the diazo dye. The interferences that you might see: false positives due to highly pigmented urine, false negatives due to improper storage and levels of nitrate. Nitrites. Positive nitrite test on the dipstick indicates urinary tract infection, cystitis, or pyelonephritis. I want you to understand and remember that not all bacteria are capable of reducing nitrates to nitrites. So you can have bacteria present and the nitrite pad does not turn positive. That is a possibility. A negative nitrite result does not mean that the person doesn't have an infection. So the reagent strip utilizes nitrite that reacts with aromatic amine to form diazonium salt, which then reacts with a dye to form a pink color. Interferences: false positives, old urine containing bacteria or pigmented urine. False negatives, that good old vitamin C again. Antibiotics can do this. Diet low in nitrates, heavy bacterial concentrations that are reducing nitrate all the way to nitrogen, and bacteria capable of reducing nitrates to nitrates. This leads us to leukocytes. The reagent strip detects lysed leukocytes, so an acid ester reacts with leukocyte esterase to form an aromatic compound that reacts with a diazonium salt and it forms a purple color. Indicates that there is possibly a urinary tract infection or some kind of inflammation of the urinary tract. So if you see nitrates are positive and leukocytes are positive, probably correct in assuming a UTI. Specific gravity. These values are given in increments of 0.005. monitors hydration status, loss of renal concentrating ability, and good for monitoring diabetes insipidus. The reagent strip utilizes a polyelectrolyte ionization, producing hydrogen ions, which in turn cause a change in pH, which causes a color change. Interferences include elevated protein or ketone levels with a false positive, and pH greater than 6.5, you want to add 0.0005 to the reading. Again, this we're talking about this in the reagent strip or the dipstick method, not the refractometer or urinometer. Confirmatory testing. The CliniTest is something that will detect other reducing sugars other than glucose. The pad on the dipstick only detects glucose. So this is very important for pediatric patients under the age of 2, I believe, where you could be detecting galactose. And so if they have galactosemia, it could be present in the urine, but the dipstick isn't going to pick it up. And it's important to detect that for children under the age of 2, or in some states it's under the age of 3, to detect those inborn errors of metabolism so that can be fixed. The ACE test is used to detect ketones in urine or serum, and so it's just confirming that perhaps the ketone pad was iffy or you're not sure. You can do an ACE test to determine, yes, indeed, there are ketones present. The ICTO test is a confirmatory test for bilirubin, and it uses, it's a tablet, it should say tablet, using diazonium salt, and it's just confirming, again, the reagent strip method. And a lot of times you need to do this if a urine sample is very, very highly pigmented. Because of that bilirubin, it's sometimes hard to read the dipstick pad, so you need to confirm that with the ICTO test. I have some links here that I thought were actually very useful, and I'm not going to go here during this session because it'll probably do something crazy and I'll lose you all, but definitely as you're studying for your boards and certainly your exam, take a look at this. They're all from Cornell University, and they show you reactions of the ACE test, the ICTO test, and then they also show a nice overview of how casts are formed and crystals, and they have some really nice images. And we're going to be talking about casts, crystals, and other formed elements in the next review session, urinalysis number 3, coming up. Think about what questions you have concerning this review session, and I look forward to hearing from you in the live Q&A.